Let us now learn about the visual pathway. Visual pathway is concerned with reception, transmission, perception of the visual impulses. The main pathway connects retina with the visual cortex. Now this is concerned with identifying the shape, color, motion and depth perception of the objects within the visual field. There is a minor part of the pathway which connects retina with the structures in the midbrain and diencephalon. Now this part is concerned with the saccadic eye movements, visual reflexes, circadian rhythm and arousal responses. Visual pathway is sensitive to visible light, which is within the spectrum of light. It is present between 350 nanometers to 750 nanometer wavelength of light rays. Like any other ascending pathway, visual pathway is also a three-order neuron pathway. Its first-order neurons are the bipolar neurons, second-order neurons are the ganglion cells, and the third-order neurons are the neurons within the lateral geniculate body. But how it differs from other ascending pathways is that both first and second-order neurons are present in the peripheral retina. In case of other ascending pathways, second-order neurons are always present within the central nervous system. The second way in which visual pathway differs is, usually the fibers of the second-order neurons will cross to the opposite side in case of other pathways, whereas in case of visual pathway, this crossing is only partial. That is, the fibers which are starting from nasal half of the retina will cross over to the opposite side, but those which will be beginning from the temporal half of the retina do not cross. So in these two ways, the visual pathway differs from the other ascending pathways. Now coming to the various components of visual pathway, it begins from the retina in the eye, which is a photosensitive layer. From here, the light impulse is converted into electrical impulse, and that impulse is carried through various components of the visual pathway. Those components include optic nerve, optic chiasma, optic tract. Now this optic tract has two routes of termination. The larger lateral route will terminate in the lateral geniculate body. This will then transfer the information to the visual cortex through either optic radiation or through the Meyer's loop. So these two pathways, that is optic radiation and Meyer's loop, will carry the information to the visual cortex. So these are the main components of the visual pathway. So it begins from the retina, where the light impulse is converted into electrical impulse. This information is then carried through the optic nerve, optic chiasma, optic tracts, lateral geniculate body, and from the lateral geniculate body either through optic radiation or through the Meyer's loop to the visual cortex. In addition, there is a medial route of the optic tract which will transfer the information from the retina to some of the structures within the midbrain or in the diencephalon. Now coming to individual components of the visual pathway. First, let us begin with the visual field. Now this is the central part of the binocular visual field. What you're seeing as a dark circle, dark purple circle in the center is the point of fixation. Let us say right now you're looking at the screen on your laptop or mobile. Let us say you're concentrating on this central dark purple circle. That's your point of fixation. Now when you're looking at that central dark purple circle, you will also be seeing a lot of peripheral area through your both eyes. Now that is your entire field of vision. Now that common area which is common to both eyes is what is marked in the light purple circle. Now this area is flanked on either side by what is known as monocular crescent. Now these crescentic areas on either extremes will be perceived only by the respective eyes. You can test it right now. Try and close your right eye. Before closing your right eye, first mark your field of vision when both eyes are open. Now close your right eye. You'll suddenly feel that some part of the visual field which was present on the right side is now not visible. Now that part of the visual field was the monocular crescent for the right eye. So this is what you're perceiving when your both eyes are open. Let us say you open one eye at a time. So we will be concentrating on the areas on either side of this binocular vision now. So with either left eye or right eye, you have got 2 points of fixation now. Left eye fixing on the circle on the left side, right eye fixing on the circle on the right eye. Though I'm showing it simultaneously, mind you, this is done only when one of the eye is closed. Now, left half of the visual field as perceived by any one of the eye is going to be perceived by the right half of the retina. So I've shown the left half of the visual field in blue color, that is perceived by the part of the retina which is marked by blue color in both eyes. So in case of left eye, that is the nasal half of the retina because it is on the medial side. In case of right eye, it is the temporal half of the retina because it is on the lateral side. So put in other words, left half of the visual field is perceived by right halves of the retina. Now completing the same thing forward, the right halves of the visual field is perceived by the left half of the retina, that is left temporal retina and right nasal retina will be looking at the right half of the visual field. Similarly, upper half of the visual field is perceived by the lower half of the retina and lower half of the visual field is perceived by the upper half of the retina. This whole scenario is because eyeball per se is a spherical structure and we have a biconvex lens in the center through which the light rays will pass. Therefore, the image will be inverted when it falls on the retina. Now, after understanding this information, let us move on to the pathway of light as it passes through the eyeball. So, the structures which it crosses through will be from front to back: cornea, anterior chamber, pupil, then it passes through posterior chamber and then through the lens, then through the vitreous humor, finally to reach the retina. Now, retina is the area which is a photosensitive layer within the eyeball. That's the innermost layer. Retinal layer in itself is made up of 10 layers. The outermost layer is the pigment cell layer. Immediately inside that we have the layer of photoreceptor cells. There are two types of photoreceptor cells, rods and cones. Rods are more than 100 million in number. They are sensitive to low intensity light. They are not color sensitive. They are predominantly present on the peripheral part and absent in the center of the retina. Cones, on the contrary, are only about 7 million in number. They are sensitive to high intensity lights. They are sensitive to colors. They are predominantly present in the central part of the retina and become sparse as you go towards the periphery. Based upon which color they are perceiving, the cones can be classified as red cones, green cones and the blue cones, otherwise known as L, M and S type of cells, standing for long, medium and short wavelength type of light. Now these rods and cones, being photoreceptive or photosensitive cells, they act as transducers, converting this light impulse into an electrical impulse. Now this electrical impulse will hyperpolarize most of these cells, and this information is then transmitted to the first order neurons of the visual pathway, that is the bipolar cells. Now these bipolar cells are also located within the retina. Depending upon whether these bipolar cells will synapse with rods or cones, they are of two types: cone bipolar cells and rod bipolar cells. Cone bipolar cells are again of three subtypes: midget cells, blue cone cells and diffuse cone bipolar cells. Compared to the number of rods and cones, the number of bipolar cells is much lesser, so there is going to be convergence of information. Now these bipolar cells will then transmit the information to second order neurons, which are the ganglion cells. Now ganglion cells are also located within retina. Number of ganglion cells is much lesser compared to the number of bipolar cells, so again there is going to be convergence of information. Now based upon what type of cells or which lamina they are going to project within the lateral geniculate body, ganglion cells are further classified into three types: X or a P type, Y or a M type, and W or a non-P non-M type of cell. Now P stands for parvocellular, M stands for magnocellular. So the X type of cells will project to parvocellular laminae in the lateral geniculate body. Y type of cells will project to magnocellular laminae in the lateral geniculate body, and W cells will project to interlaminar zones which do not have either small cells or large cells. That is, it is neither magnocellular lamina nor a parvocellular lamina. So dendrites of these ganglion cells will synapse with the axons of the bipolar cells, and axons of the ganglion cells will continue as the nerve fibers within the optic nerve. So those are the ones which are carrying the information from the retina outwards towards the lateral geniculate body. Two other points of interest within retina are, firstly, we have an area known as macula lutea. It is an yellowish area with a central fovea centralis. Now this is the area which has maximum visual acuity. It is made up of entirely cones only. There are no rods here at all in the fovea centralis. And this is located in the posterior pole of the eyeball. That is, if there is a light ray passing straight through the eye from its anterior pole passing through the center of the lens, the point where it hits on the back of the retina, that is the place which is known as fovea centralis. The second point is the optic disc. This is about 3 millimeters medial or nasal to the fovea centralis and also 1 millimeter at a higher level. Now this is the point from where optic nerve begins. It is also the point where the central artery and central vein of retina will divide to supply the quadrants of the retina. There are no photoreceptor cells here, so this area is completely insensitive to light. It measures about 1.5 millimeters in diameter, and because it is insensitive to light, this is the area which is known as blind spot. Now for the rest of the histology details of retina, please visit this YouTube video, or you can visit the site and check on to the chapter on retina. Now coming to the next part of the visual pathway, that is the optic nerve. Now optic nerve is also considered as optic tract because the retina itself is an outgrowth from the central nervous system. So because it is connecting retina with the rest of the central nervous system, it is connecting two parts of CNS itself, therefore can be likened to a tract. It's made up of 4 parts. An intraocular part which is 1 millimeter in length, that is the portion which is forming the optic disc, and that is where the nerve fibers are non-myelinated. The second part is the intraorbital part, which is about 25 millimeters in length. This is a portion which is traveling within the orbit, within the circle formed by all the 4 recti muscles, till it reaches the optic canal. Now here, the nerve fibers within the optic nerve will all be myelinated. So what has started as 1.5 millimeter diameter optic disc will now be reaching a nerve with a size of more than 3 millimeter diameter. Roughly about 15 millimeters before the eyeball, central artery and central vein will pierce this optic nerve. The third part is the Intra Canaliculi part, which is about 8 millimeters long. And this is the part of the optic nerve which will be passing through the optic canal. Here it will be accompanied by ophthalmic artery. And fourth and the final part is the intracranial part, which is about 15 millimeters long. After the nerve enters the cranial cavity after having passed through the optic canal, till it reaches optic chiasma. That portion is the intracranial part. The reason why this nerve is different compared to any other peripheral nerve is because firstly it is covered by meninges. Every other peripheral nerve will be covered by epineurium, whereas this is going to be covered by the sheath of dura, arachnoid and pia mater. Secondly, all other peripheral nerves are myelinated by Schwann cells, whereas this is myelinated by oligodendrocytes. Thirdly, the perineurium will divide the other peripheral nerves into multiple fascicles. Here, the optic nerve is divided into multiple bundles by sheaths of pia mater. Fourthly, this nerve stands out differently from the rest of the peripheral nerve because right in the center of this nerve, we see the sections of central artery and central vein of retina. In fact, that is one of the way in which we identify this section under microscope. And the nerve fibers in the optic nerve do not have neurolemma. So if there is injury to the nerve fibers, there is no regeneration. So in all these ways, optic nerve differs from other peripheral nerves, and moreover, it resembles a central tract. So it is more likely to be called as a tract rather than a nerve. Now coming to the next portion within the visual pathway, that is the optic chiasma. Now this is where the fibers starting from the nasal halves of the retina, they will be crossing over. So the left nasal fibers will cross over to the right side and vice versa. Within this optic chiasma, almost the central 2/3 is occupied by the macular fibers. The anterior portion is occupied by the peripheral retinal fibers. In the posterior portion, there is what is known as commissure of Gooden. Please note, this commissure of Gooden are the fibers which are starting from medial geniculate body, which is actually a part of the auditory pathway. They travel with the optic tract in the opposite direction, reach the optic chiasma, cross over to the opposite side and reach the medial geniculate body of the opposite side. So within the optic chiasma, not only the fibers of the visual pathway are crossing, even the fibers of the auditory pathway are crossing. Now coming to the relations of optic chiasma, it is related above to the sheet of white matter known as lamina terminalis. Below it is related to the bony sulcus known as sulcus chiasmaticus, which separates the anterior cranial fossa from the middle cranial fossa. Above and behind, it is related to cavity of third ventricle with the optic optic recess. And below and behind, it is related to pituitary gland covered by the diaphragma cellae. Now this is an important relation because in case of pituitary adenomas, it will grow upwards and compress the optic chiasma from below. Posteriorly, it is related to tubercinarium and infundibulum. You will recall that optic chiasma forms the anteriormost boundary for the interpeduncular fossa. So immediately behind that, it will be related to tubercinarium and infundibulum of the pituitary gland. And on either side, optic chiasma is related to anterior perforated substance, within which we will also find the internal carotid artery. So this is again an important relation because aneurysm of the internal carotid artery in this region will result in compression of the optic chiasma from the lateral side. Now both these, that is compression by the pituitary gland from below or compression by the aneurysm of internal carotid artery from lateral side, will result in certain visual field defects. Now moving on to the next portion, that is the optic tract. Now each optic tract contains fibers coming from the ipsilateral temporal half of the retina and contralateral nasal half of the retina. The tract extends from optic chiasma to the lateral geniculate body. It will be winding round the cerebral peduncles. This optic tract towards the posterior end has two roots. The larger lateral root will relay in the lateral geniculate body of the same side. Then there is a medial root. Now this medial root will project to various structures within the midbrain as well as in the diencephalon. Some of these fibers will project to superior colliculus. Now these fibers are involved in automatic scanning movement of the eyes. Some of the fibers will project to pretectal nuclei. They will be involved in pupillary eye reflex or the light reflex. Some of the fibers will project to reticular formation in the midbrain. Now they are involved in arousal response. Some of the fibers will project to the suprachiasmatic nucleus of the hypothalamus. They are involved in circadian rhythm. And finally, some of the fibers will also project to the pulvinar part of the thalamus, which are involved in blind sight. So optic tract has a lateral root which will be a part of the main visual pathway, and which will be projecting to lateral geniculate body, and there is a medial root which will project to various structures within the midbrain as well as in hypothalamus and thalamus. Next portion is the lateral geniculate body. Now this lateral geniculate body is having 6 laminae as shown in this right side box here. Lamina 1 and 2 are made up of large cells, so they are the magnocellular laminae. Laminae 3, 4, 5 and 6 are made up of smaller cells, so they are the parvocellular laminae. You will remember that each optic tract has ipsilateral temporal retinal fibers and contralateral nasal retinal fibers. So within the lateral geniculate body, laminae 1, 4 and 6 will receive information from the contralateral nasal half of the retina, and laminae 2, 3 and 5 will receive information from the ipsilateral temporal half of the retina. And within the lateral geniculate body, there is also visiotopic arrangement, that is periphery of the retina is projected or represented more anteriorly, whereas the vertical meridian including the macula will be represented more posteriorly. Now, we were talking about the ganglion cells of 3 types, that is P type, M type and the W type, which are non-P, non-M type. So the P type cells will be projecting to laminae 3, 4, 5, 6. M types of ganglion cells will be projecting to laminae 1 and 2. And the W type cells, which are non-P, non-Y, they will be non-P, non-M, they will be projecting to the zones between these 6 laminae as well as to the lamina which is named as S. So those will be the areas where the W cells will be projecting. So the lateral geniculate body will receive its afferents from the optic tract and sends its efferents through 2 fiber pathways. One is the optic radiation, second one is the Mears loop. So let us find out what they are. Both this optic radiation and the Mears loop together will form what is known as geniculocalcarine tract, because they start from the lateral geniculate body and they go to that part of the cortex which is around the calcarine sulcus. Now, optic radiation is the part which is starting from the lateral geniculate body. It travels in the retrolentiform part of the internal capsule, reaches the occipital lobe to that area which is in the depth as well as above the calcarine sulcus. So the portion which is the part belonging to cuneus. Now this is carrying information from the upper half of the retina, and therefore it will be having information about the lower half of the visual field. Coming to the Mears loop, now this is the portion which is starting from the lateral geniculate body. It is carrying information from the lower halves of the retinae. It will travel with the sublentiform part of the internal capsule. First it will reach the temporal lobe, then it will turn back to reach the occipital lobe, the lower portion of the occipital lobe. So it will reach the lingual gyrus, which is the area below the calcarine sulcus. Because it is carrying information from the lower half of the retinae, it will be having information about the upper half of the visual field. Now moving on to the last part, that is the visual cortex. Now visual cortex, especially the primary visual cortex, is the area around calcarine sulcus. So it includes the area within the depth of the calcarine sulcus, part of the area in the cuneus, part of the area in the lingual gyrus below it. It also extends onto the superolateral surface up to the lunate sulcus. Now within the visual cortex, image is topsy-turvy. Firstly, the right-sided visual cortex receives information about left half of the visual field. So now if you're looking with both your eyes open, let us say you draw a line at the level of your nasal cavity, whatever visual field you have on the left half, that will be perceived by your right-sided cortex and vice versa. Secondly, within the visual cortex, macula has a representation posteriorly and periphery of the retina is represented anteriorly. Above the calcarine sulcus, that is receiving information from the upper half of the retina through the optic radiation. Now this is receiving information from the lower half of the visual field. And the lower part of the visual cortex, that is the lingual gyrus area, that is receiving information from the lower half of the retina through Mears loop. So that will be receiving information about upper half of the visual field. So image is completely topsy-turvy. However, what is perceived in the primary visual cortex is just a simple image of the visual field. We did mention about the magnocellular laminae and the parvocellular laminae in the lateral geniculate body. Now before we started, that is in the geniculate ganglion cells itself in the retinae, we said that there were typical set of cells which projected to lamina 1 and 2, which are the magnocellular lamina in the lateral geniculate body. And then there are ganglion cells which will project to laminae 3, 4, 5, 6 or the parvocellular laminae in the lateral geniculate body. So the fibers which start from lamina 1 and 2, when they reach the visual cortex, they project on certain neurons. Axons of these neurons will form what is known as Vert Pathway. That is, they are the ones which are sensitive to motion of any or movement of any object within the visual field and also position of any object within the visual field. Those fibers which are coming from the parvocellular laminae of the lateral geniculate body, they project to the remaining neurons in the visual cortex. Now axons of those neurons which receive the parvocellular laminar input, they will form what is known as Vert Pathway. So they project to the inferior temporal cortices and they will be involved in identifying what is the object. We had discussed the visual cortex in detail in our video on the occipital lobe functional areas. So you can revisit that video to revise the details about visual cortex. So we now move on to the blood supply of the visual pathway. Retina is supplied by central artery of retina predominantly and also from the blood vessels which are present in the choroidal layer. Extracranial part of the optic nerve is supplied by branches of ophthalmic artery, whereas intracranial part of the optic nerve along with optic chiasma are supplied by branches of anterior cerebral artery, anterior communicating artery and some of the direct branches coming from internal carotid artery. Optic tract is supplied by branches of posterior communicating artery as well as anterior choroidal artery. Lateral geniculate body is supplied by both anterior and posterior choroidal arteries. Coming to the optic radiation and Meyer's loop, they are supplied predominantly by the branches of middle cerebral artery, also by a few branches of posterior cerebral artery. Coming to the visual cortex, it is predominantly supplied by the branches of posterior cerebral artery and also by a few branches coming from middle cerebral artery. Now coming to the visual field defects. I have marked the site of the defects on the left side in the picture and the effects are cited on the right side. The rightmost end of your screen shows two circles. They mark the visual field of each eye. So let us find out one by one. Firstly, what is not shown here is there could be any damage within the retina itself that will result in local blindness of that much area within the visual field known as scotomas. Now we start with the lesions in the numerical order. The first lesion, numbered as 1, that is the lesion to the optic nerve. In this case I have shown there is lesion to the right optic nerve that will result in monocular blindness. So right eye is completely blind if there is lesion to the right optic nerve. Because there is no light impulse being transmitted through the optic nerve, there will be no pupillary reflex also. So when you shine the light in the right eye, there will neither be direct light reflex nor will there be consensual light reflex in the opposite eye. Then there is lesion number 2, that is lesion through the optic chiasma central part. Now this is the area where the nasal fibers from both retinae will be crossing over to opposite side. The lesion to this area is usually due to a tumor arising from the pituitary gland. As it enlarges, it will compress the optic chiasma from below. So the central part getting compressed will result in blindness to the outer halves of the visual fields, what is known as bitemporal hemianopia. Let us first understand this terminology. Anopia is blindness, hemianopia half blindness. In the visual field, the bitemporal halves of the visual field will be having blindness, but nasal half of the visual field is intact. So that is why bitemporal hemianopia. Then the lesion number 3, here the lateral parts of the optic chiasma are compressed, most likely because of the aneurysm present in the internal carotid artery at that site. If it is present on both sides, then what we get is a binasal hemianopia. Now these are the fibers within the optic chiasma. Here we have the temporal side of fibers. They will be looking at the central part of the visual field. So central part of the visual field will be having blindness, the periphery will be intact. That is called as binasal hemianopia. The lesion number 4 is the lesion to the optic tract. You know that each optic tract carries fibers from the ipsilateral temporal half of the retina and contralateral nasal half of the retina. So the right optic tract will be looking at the left half of the visual field. So if there is lesion to the optic tract, there will be homonymous hemianopia. That is, for both eyes, the left half of the visual field will be blind. However, the field of vision which is lost in both eyes will not be exactly corresponding. That is what is known as incongruous or incongruent homonymous hemianopia, because as the optic tract fibers come towards the posterior end, they are dividing into medial root and lateral root. So the fiber division will be slightly different on right and left side. Therefore, the amount of field of vision which is blind on the right eye will not exactly correspond to the amount of field of vision lost on the left eye. That's what we call it as homonymous hemianopia of incongruent type. Plus, in this case, there is what is known as Wernicke's reaction present. Wernicke's reaction is, let us say this is the right optic tract being involved. So if you shine light in any one of the eye now, if you're shining light in that part of the retina which is involved because of the right optic tract involvement, then there will be no pupillary reflex. But if you shine light in the opposite half of the retina which is not involved in the lesion to the optic tract, then there will be light reflex will be present. So it is not the complete presence or absence of the light reflex. It is depending upon where you are shining the light. So if you are shining the light in the right-sided temporal retina or left-sided nasal retina, then pupillary reflex will be absent. Whereas if you shine it in the right-sided nasal half of the retina or left-sided temporal half of the retina, then in that case light reflex will be present. This is what is called as Wernicke's reaction. So a lesion to the optic tract will have Wernicke's reaction present. Then if there is a lesion to the Mayer's loop numbered 5, Mayer's loop is carrying information from the lower half of the retina, therefore upper visual field. So in this case, the patient will have right upper quadrant anopia. So upper quadrant will be having blindness. However, the fibers which have started from the optic tract and gone through the medial route to reach the pretectal nucleus, they will complete the circuit. So light reflex will be present here. Similarly, if there is lesion to the optic radiation, there will be lower quadrant anopia. Again, light reflex will be present. If there is lesion to the visual cortex, then there is homonymous hemianopia, because you know that visual cortex, like if it is a right-sided visual cortex, it receives information from the left half of the visual field. So there will be homonymous hemianopia, but there will be macular sparing. Now macular sparing is because of one of the three reasons. One, because the area which is representing the macula in the visual cortex, that gets dual blood supply. So most often the lesion being due to vascular cause, even if one of the artery is involved, other artery will be spared, so the macular area will be spared. That is one reason. Reason number 2 is macula itself is a very small area which is represented by a large area of representation in both the cortices. So even if one cortex macular area is affected, the other cortex is normal, so the macular area is spared. That is because of the dual representation. That is reason number 2. The reason number 3 is when you are asking a patient to focus on any one field, he may just shift his head slightly laterally. That will adjust to the macular area. So that's just a common sense activity. So that is the reason why the macular sparing could be recorded. So any one of these reasons will result in macular sparing. In an event when bilateral visual cortices are affected, then only the macular area will be spared in both sides. So that will result in tunnel vision. So only the central part of the field will be intact. The entire periphery will be absent. That is called as tunnel vision. Even in this case, light reflex will be present. So these are the various visual field defects. Now based upon the presentation, you can roughly identify what is the site of lesion. Please visit the video on retina to know the histology of retina. Please visit the functional areas of occipital lobe to know more details about visual cortex and various visual areas. With this, we come to the end of visual pathway and visual field defects. Thank you very much. You can visit this site for other neuroanatomy videos.